Hi, this is John Cook. I'm chair of the Department of Cardiovascular Sciences, and I'm here today with Dr. Alan Daugherty, who is professor and chair of research at the Gill Heart Institute, and gave us a wonderful lecture of his work at University of Kentucky on aortic aneurysm pathobiology. So we'll talk about that in just a moment, but Alan, tell us a little bit about your background. You were born in Liverpool.
Correct, yeah. I was born in Liverpool, which is a town that has got quite some famous music and sport basis to it. It was a fun town to grow up in, even though it was a tough town. I went to college in the northeast of England in a town called Sunderland, which was also an interesting, tough place. And then I did my PhD in electrophysiology in the University of Bath, which is a beautiful historic town in the southwest of England.
Then what led you toward atherosclerosis? You went from electrophysiology to atherosclerosis pathobiology.
Correct. So when I was doing my PhD, I got really interested in a hypothesis that lysophospholipid would be a provoking factor of ventricular arrhythmias. And the person that was leading that charge was Burton Sobel, who was head of cardiology at Washington University. So I, as an ambitious little PhD student, I wrote to Dr. Sobel saying, you know, would he consider taking a British guy in to do a postdoc? And I got an immediate result, of which he invited me over. But when I got there, you know, it was part of a huge cardiology program there. WashU was a thriving cardiovascular research institute, and there was many options, should we say. And it's a long story, but the bottom line is that I was persuaded that maybe I should think about atherosclerosis, both in terms of basic mechanisms and also imaging aspects of that. So my early postdoc made me switch fields very dramatically, but that's been kind of a long-term focus now for about 3 decades.
And from there you went to University of Kentucky.
Yeah, so I came over for 2 years, and I'm still here. I was going to be a fellow at Washington University for 2 years and then go back. But I really fell in love with the research environment in the States. It's just streets ahead of what I was experiencing back in Britain. And I really liked the academic environment. I really liked sticking around, and I really liked the environment at Washington University. So I ended up transitioning from being a fellow there to being on faculty for another 12 years. And it just so happened very serendipitously, an opportunity came for me to visit University of Kentucky in '97. I got there, Jim Muller had just been brought in from BI in Boston to head up the cardiology unit then. And Jim, who you may know, is a very diverse individual in terms of he's got a part of the Nobel Prize group for his efforts towards nuclear disarmament. And
The Nobel Peace Prize.
The Nobel Peace Prize, yes. And as part of that, you know, Jim had come up with this concept of the vulnerable plaque. That's where the term vulnerable had come up, is because of his work in nuclear disarmament. And he coined this term and was very interested in starting an atherosclerosis group at Kentucky. And it seemed to fit in perfectly with my background in terms of the pathology. Plus, there was a really great lipoprotein group at Kentucky. A lot of people I've known for many, many years happened to have been recruited. Wim de Villiers just came out of Simon Gordon's lab to work on macrophage biology. Denise van der Westerhuizen just moved from Cape Town. He worked with Goldstein and Brown previously on the LDL receptor morphology. The group had just come up with new splice variants of SRB1, which is the newly recognized HDL receptor. So there's a rich diversity of people that seem to interact very closely with my atherosclerosis interests. So it seemed like a very natural theme to get back into a very active cardiology unit with a diversity of people that, you know, I really like interacting. I don't think science doesn't happen in isolation, and this seemed to be a great opportunity to be integrated into a group.
The program in atherosclerosis and cardiovascular medicine has really grown at University of Kentucky, and you hold the Gill Chair in preventive cardiology. And tell us a little bit about your benefactor and how Jack Gill's work has helped transform the University of Kentucky's program.
So I was very fortunate that I moved to Kentucky in September of '97. Linda, who graduated from the University of Kentucky, made her visit that I knew of anyway in October of '97, interacted with the cardiology division. Both her and Jack would then return on several occasions. ultimately culminating in December when they provided funds that were the seed money for developing our physical institute, the Linda and Jack Gill Heart Institute. It's actually now called the Heart and Vascular Institute as of a few weeks ago. They provided a chair, which I'm fortunate enough to hold, and also some other funds to help research. And it wasn't just their financial commitment, actually. It was more their awareness of making sure people are very aware that Kentucky has a very large cardiovascular disease problem, and the burden there is much higher than most states. So they are, as you well know, tremendous advocates on issues that they have passion about. And I can assure you Linda has incredible passion about the health of people in Kentucky. So it's not just been the financial contribution, they've been regular visitors. We have a annual research day, which you're one of the distinguished faculty of previous years. They've attended it every year in the 20 years that we've had it. They've been present at very important aspects of interacting with our politicians to discuss this. They've made multiple visits out into our eastern region where cardiovascular disease is incredibly prevalent. They've just been great advocates of not only just philanthropic assistance, but advocates because of their incredible passion and enthusiasm.
They've been active here in Houston as well. Linda is one of our very treasured volunteers working at the Methodist Hospital. And Jack, of course, runs an entrepreneurship course at Rice University.
Which actually is now telecast into Kentucky, so we get the benefit of that as well. Actually.
Great. Yeah. Tell us a little bit about aortic aneurysms in the few minutes that we have left here in this interview.
So, I got into this in a very backdoor way. As I mentioned during my talk, I got into this because I started interacting with the vascular surgeons at Washington University. Bluntly, as my mother-in-law worked in vascular surgery for 46 years at WashU as a nurse in the facility and introduced me to a lot of the surgeons there. And it was actually a great education for me as a PhD to get suddenly educated into a disease which at the time was repaired by open surgery, which was very traumatic. Had the benefit of us acquiring tissues at the time, which I didn't realize that was going to get a very rarity down the road. But it really illustrated that these diseases, which are so prevalent, really have a very poor way of treating these individuals. And, that people are diagnosed with it. The psychological parameters of just knowing people have this disease with no obvious mechanism we can do for medical therapy, is really quite a devastating aspect.
So understanding the pathobiology, which you have done, contributed a great deal to the understanding of pathobiology of aortic aneurysm. That could lead to new therapies. And what do you see down the line in terms of, based on your understanding of the pathobiology of aortic aneurysms, what therapies do you think might be useful down the line?
Well, so there's been a contrast of the new versus the old in this discussion because clearly what we're seeing is a provocation of the disease through an angiotensin-based mechanism, of which there's now multiple approaches to be able to pharmacologically inhibit that system. Now, ACE inhibitors are obviously very generic and have been used for many years. ARBs are the renin inhibitor work that we were involved with Novartis in the early days. We think could have been extended much greater. Clearly, we have enthusiasm to really focus on what we think is one of the initial provoking factors, which is the angiotensin system. On the other side of it, there is, especially in Marfan's tremendous amount of effort and intent to look at things like TGF-beta. And, that also is a very interesting, but in many ways much more conflicting field. But there are advocates for looking at TGF-beta regulation. Unfortunately, that one was, with angiotensin, everyone I think is realizing that inhibition is good. TGF-beta has got very extreme interactions with people thinking TGF-beta is good or bad, and that's where the field really needs some clarification because there are ways of antagonizing TGF-beta now, so this is a therapeutic possibility. And we really need to have a better feel for the pathobiology as to whether we should start getting into this.
And just one last question back to the garden variety aortic atherosclerotic aneurysms. The role of lipids there, you've shown is very important. What about some of the new lipid-lowering agents? Any evidence that they might also be useful for slowing the progression or reversing the progression of aortic aneurysm?
So the evidence of, at least in the abdominal segment, clearly all these patients quite often have a lot of comorbidities, so they're frequently placed on a statin to lower cholesterol. In many ways, just because of the general comorbidities, it's considered to be a recommendation. Whether they have a direct effect on the abdominal segment at the moment is certainly not clear, and has been not directly looked at in a double-blind clinical trial. But at the moment, it seems to be a rather weak effect. So that there is a lot of evidence that aneurysms and athero are quite different. I mean, the classic differential is diabetes, which obviously is a huge provoker of atherosclerosis, and very consistently is shown to be actually protective against aneurysms.
Yeah,
so there are some alignment of risk factors, but in terms of blood pressure and lipids, the intensity that they're linked with athero does not seem to parallel the intensity in aneurysms.
Well, Alan, thanks so much for joining us today. We really enjoyed the lecture, and thank you so much for spending some time with the interview.
Appreciate your great hospitality. Thank you.